Hello. The next session will be chaired by Dr. Manjeet Mohi, who is a professor and a head of obstetrics and gynecology at Gyan Sagar Medical College, uh, Ramnagar. So, Dr. Manjeet, please. The next speaker is Professor Joseph Mathews, who is in pediatric pulmonology, APC PGI, and he is a very brilliant researcher. He'll be speaking on better medical writing. Dr. Mathews, please.
So thank you very much, Madam Chavla and everyone else for this invitation. I'll plunge straight into the topic. Now, why do we write research experiences? It's either usually to describe some unique experiences, which are usually case reports, series, or other observations, or sometimes more specifically to report an answer to a specific research question that we had. And this is the part which Professor Datta covered very nicely with observational studies and experimental studies. So when we're reporting answers to a specific research question, the key thing is, what is that question? And I think we didn't deliberate enough on this important topic of research questions up till now. So I will just frame very briefly this framework for research questions. It's called PICOT. It is an acronym wherein each letter stands for something that is important. P for the population or problem, I for intervention or exposure, C for comparison, O for outcomes, and T for the time frame. These words by themselves don't make much sense until we look at the next column in the table, which is basically saying which disease, what kind of people are we talking about, what did these people get. If the investigators gave it to them, it's called an intervention. If they got it naturally, then it's called an exposure. And what was it compared against? That is the C component. What was actually looked for, measured, evaluated, or assessed? Those are the outcomes. And over what period of time? So to give a very simple example, I thought we'll take something which is currently of importance. And that is, if we were looking at a study which looked at vaccinating pregnant women who are at risk for getting COVID, that would be a good P, which includes both the population and the problem. The COVID vaccine given to them would be an intervention. There would be another group of similar people who didn't get the vaccine. They would be the comparison group. And we could look at parameters of efficacy like protection and things like that, and even safety. And these things, the measures of outcome, have relevance only if there is a time frame in which they are described. And let's say for this particular example study, it's about 3 months. Of course, if we needed to look at the efficacy or safety in terms of protecting the babies of these pregnant women, then we might need to follow them to delivery and even beyond. So I think we'll use this framework of PICOT everywhere because it's important to remember this, and it comes up in all the discussions on doing research, reading research, appraising research, and even assessing the research of other people. And we'll use this example that I just gave for making it clear. Now, looking at the parts of a paper, I think this slide we're familiar with. Everyone knows the parts of a conventional research study paper. So this is just put up there for completion. The question sometimes comes, where do we start, among all these sections? And I think some good journals these days have a little policy to have at the end of the paper or somewhere in the paper, 3 or 4 bullet points on what is known about this topic and what does this study add. And that is because neither editors nor readers are interested to really read about something which they already know about. So this kind of a paper, however well written, for this kind of an audience is not really going to be appreciated much. It is a good place to start there because it gives us a point on what we know and what we have added to that literature. The only suggestion I have is we can reframe these 2 points. What do we know about the PICOT question? And what is this study that we have done adding to that PICOT question? And it will be a good place to start our writing because things will move from there. Once that is clear, we can go into the introduction section of our paper. And the introduction section is usually just 3 paragraphs. The first paragraph talks about the problem and the population. In the example I just gave, we would say COVID is a big disease. It's all over the world. It's also there in India. Pregnant women are getting it, this and that, statistics and numbers and things like that. That describes the population and the problem. The second paragraph usually would talk about the intervention, the comparison, and the outcomes. In the example I gave, we would say that there are 3-4 vaccines which are available. This is the efficacy, and nobody has really looked at different subgroups of the population. And that brings us nicely into the third paragraph, which describes first the rationale for our research study. In this case, what we would say is, that the COVID vaccine has not really been tested in pregnant women. So I'm going to be one of the first researchers doing that because there is lack of data and it's also an important subject. And then we would frame a research question incorporating the elements of the PICOT that I listed previously. So those 4 or 5 phrases which I used, if we can put that into a nice sentence, such as what is the efficacy and safety of the COVID vaccine, which is available in pregnant women at risk for COVID compared to not getting any vaccine, that becomes a nice PICOT question. And everyone knows by the end of the introduction section what the paper is dealing with. Once that is done, we can go into the materials and methods, or what is just called methodology. Basically, in one word, it reflects what has been done. And there are several subsections. It always starts with mentioning whether ethics approval was taken and whether informed consent was taken from research participants. These days, it's not a good idea to try and publish anything without these two components. And then, of course, trials need to be registered, or there is an online protocol facility for most of the research studies. Then comes the real information that we're conveying to the readers, which is a study setting, study duration, the study design. Dr. Datta nicely explained that the same research question can be answered with multiple study designs. And these study designs have a hierarchy. And those hierarchy, if we choose study designs which are towards the top, they end up with being more valid than the others. Inclusion criteria for participants, exclusion criteria, the sample size and procedures adopted. Rather than just listing these things, sometimes it's also important to provide a justification for why a particular group of researchers has chosen to do these things in a particular way as opposed to other ways. Then, of course, how was this research done? How were the samples selected? And the beautiful slide which Dr. Datta showed about the big N, which is the universe of subjects, the eligible subjects which could have gone into the research, and the actual included subjects of the small n, how they were recruited, that depends on the study design, how the intervention was given, how the exposure was allocated if it is not an interventional study, etc. And then there should be a nice description of the outcome measures. Usually there is one primary outcome and a few secondary outcome measures. Going on further, the instruments, tools, definitions used, whether it's questionnaires, tools and instruments for measuring things, how these were timed, the validity of those tools, especially if they are not global standards, and the efforts made to ensure accuracy and precision of measurements. It's very simple to understand. Blood pressure can be measured with an ordinary 200 rupees manometer. It can also be measured as accurately as putting an invasive intra-arterial line. And clearly, instruments which are calibrated and designed to produce greater accuracy and precision would be having much better accuracy in the results. Then there is a section usually on statistical treatment of data, what tests were used, how they were used. And unfortunately, this is a thing which most of us physicians shy away from because it involves numbers probably, and also because we often don't understand the jargon. And we should remember that a lot of statistics actually depends on a whole lot of assumptions in the background. And so sometimes it looks like magic to us. We're just interested in getting a p-value number or some kind of a numerical value which suggests that the results are significant. But remember, if the data is strong enough to stand on its own, we might sometimes not even need very complicated statistics. Very basic, simple statistics can give us a clear impression of what is going on. It's when the data is not strong enough to stand on its own, or the differences between the control group and the intervention group are small or difficult to differentiate as being really different or not. That's when we need to rely on a whole lot of statistics. And there is virtually no end to the complexity of statistical tests which can be used. So here is, I think, an area where we need to consult or take help from somebody who's more experienced or professional, because unless the statistics are reasonably robust, most good journals will refuse to publish the studies that we want to submit to them. And if our introduction and methodology section is complete, we can now go to the results. Again, to summarize, I think the key thing is to keep the PICOT question in mind. Sometimes what happens is we have the PICOT in mind when we did this study, the results are not supporting the thing that we thought would turn up. And so then we start diverting into side channels and subgroups and things like that. So if you have the PICOT question central, then there is no error or risk of error of this kind of a thing happening. Once you have that, you can describe the characteristics of the people who are in the study, their age, gender, and all that. We usually present a table of baseline characteristics. Sometimes we compare the baseline characteristics of the control group and the intervention group. These days, good journals don't expect statistical tests to see whether there are differences, because if it is done in a nice way, which is usually randomization, then we don't really expect to see big differences. Outcomes which are presented should be again based on the outcomes which were specified in the PICOT question. It's not a good idea to introduce new outcomes which we had not thought of, but because they showed a statistically significant result. Analysis of the outcomes is usually done with statistics, but sometimes it's possible to manage without. One key thing to remember is we don't repeat content from the methods section and start saying, we measured blood pressure and this is what we did. Not required. Tables and figures are useful to enhance the presentation of the manuscript, but they should be self-explanatory, able to stand on their own. And what is in the table then need not be repeated in the text or the figures. So using the same information presented in 3 different places is usually not a good idea. The discussion. Now, the discussion section is usually meant for us to interpret the results, not really to say, what other authors have done. And when we interpret the results, we can dwell on reliability of the results, believability of our results, and the applicability of our results. And this is usually done because if we can present the limitations and strengths in the methods that we have used, that will tell the readers whether the results that we are presenting are reasonably reliable. The efforts made by the investigators to minimize bias. Bias can never be completely eliminated. That enhances the believability of the results. And if the results are relevant to the P component of the PICOT question, then readers can judge whether it is relevant to their own population and also universally. But what should not happen in the discussion section is something like this, wherein we load the discussion with references, Gupta said this, Smith said that, Bangarappa said the other thing, 5 authors are agreeing with me, 1 is not agreeing with me. Those kind of things are not really relevant unless they're bringing out something important. And then again, conclusion. By now you would be sick of hearing me use this phrase word PICOT. Again, the PICOT is to be remembered when we write the conclusion. The conclusion section is the answer to the whole PICOT question. So if the PICOT is clear and central in our mind, we focus the conclusion to that PICOT. We should not add stuff which we have not really done by saying, oh, the COVID vaccine didn't really turn out to be protective for women, but it is very cost effective and everybody is getting it, so we should enhance the coverage rates. Those are not things which came out from our study, so it's not a good idea to do that. Doing that would be akin to this. Our actual study results have shown us this, but we are trying to overload our conclusions with things which were not actually in the PICOT question and definitely not supported by the data in our own study. That should be avoided. Once we've done the conclusion, we look at the references. I think this is common sense. Follow the style prescribed by the journal, keep the numbers minimum, list them in order, use the numbering or system what the journal has prescribed. And these days there are nice softwares to help us switch from one system to another. So this is basically common sense, mechanical, nothing great. At the end of all this, I suggest that we try to write the abstract, because the abstract is a summary of everything, not a trailer. It's not like a movie trailer in which we tantalize the readers that I'm going to tell you something exciting and interesting and adventurous. So please read the whole paper for that. So usually the abstract is best written at the end. Most journals for studies would ask for structured abstracts with background methods, etc., etc. Sometimes unstructured abstracts are preferred. 250 words is the usual word limit. Some journals go up to 400. They give you a chance to incorporate 2 or 3 keywords. The keywords are for indexing systems, which Dr. Bharti mentioned in the beginning, to help the journals and the indexing systems to identify. And finally, I think, though this looks silly, we go to the title at the end, so that the title again tries to capture the PICOT and the study design. I don't think we should focus on the main result, so the COVID vaccine is very effective in pregnant women. That's not the idea. We would rather write the title as randomized controlled trial comparing COVID vaccine versus in pregnant women at risk of COVID. Some of us have the tendency of adding one little phrase in a developing country, in a poor country, in India, and things like that. It's really not required, because if the study is interesting and stands by itself, we might not need these crutches. Now, this is my lastish slide. The top 10 reasons for rejection from an Indian journal, because I thought the top 10 reasons from a foreign journal would be slightly different. And these are very clear and common sense. You see, inappropriate research topic, poor hypothesis, poor design, small sample size, etc., etc. This is all put up on this slide. The one thing I wanted to highlight has been so beautifully covered by Professor Goyal just 15 minutes back. And that is, before you actually submit, run it through one of these softwares, free or paid, that you have, to make sure that there is no element of plagiarism, which will spoil the whole fun in submitting a paper and seeing it through to its publication. I think my 12 or 13 minutes are up, so I will stop here. Thank you, everyone.
Thank you very much, Dr. Joseph. It was an excellent presentation. I think this is something which is required by every postgraduate student and the teacher who is guiding them. I like to pass on to the experts if they want to comment upon this.
Yeah, there are no questions in the chat box, but it was a brilliant presentation, and I think all the postgraduates must have, even the guides and the co-guides, they must have also benefited from the presentation. So, and the next one is Dr. Bhaskar Thakur from Texas, USA, and he'll be speaking on brief introduction on tests of significance, statistics. It's a very, very important.
Good evening, Chawla Madam and all the organizing committee to provide me such a nice opportunity and such a nice platform. So I'm starting with this topic, the statistical test of significance. It usually take like 3 to 4 hours to cover to understand the deep concept of a statistical test of hypothesis, but I will briefly introduce the concept of a statistical test of hypothesis by explaining what is the different types of hypotheses and what is the level of significance in the clinical research, and the p-value, which is very popular in clinical research, and why we do need to supplement the confidence interval along with the p-value, and then we summarize our discussion. So what is hypothesis? Hypothesis is a premise or claim that we want to test or investigate. But hypothesis testing is generally used when some comparison is to be made. At Professor Ussa Datta suggested that there are two types of study. Mainly, one is the descriptive study and another one is the analytical study. So when we do the analytical study, then we must have the comparative group. And when we compare certain parameters between the two groups, or we compare the association between the two parameters, then we do the testing of hypothesis. And under the testing of hypothesis, we define the two different types of hypothesis. One is null hypothesis and another one is the alternative hypothesis. Nulls generally means something empty, something zero. But in a statistical sense, null hypothesis is something which is established, something which is conventional, and sometimes it could be our belief about the unknown parameters, unknown things. And that's the reason that a null hypothesis can be a true hypothesis. It could be a false hypothesis. An alternative hypothesis, actually, it involves the claim stated under the null hypothesis needs to be investigated in the testing of hypothesis. So what we do generally in testing of hypothesis that we collect some sample data from the target population and we generate some evidences, and based off those evidences, we try to reject the null hypothesis to prioritize the alternative hypothesis. And if we do not have enough evidence, then we fail to reject the null hypothesis. So we will understand through one example of this null hypothesis and alternative hypothesis. For example, few years back, some guys came and then they said that there is no difference in the incidence of measles between the vaccinated children and non-vaccinated children. But they read this information in 20 years old literature published in a European journal and some European population. Then after a couple of years later, some new guys came and then they said that, no, it's not true. This vaccine can be effective in our Indian children because our population is different. Our, the whole background characteristics is different. We share the different type of climate. Our food habit is different. So then they came with the alternative hypothesis, and then they said that there could be a difference between the incidence of measles between the vaccinated children and non-vaccinated children. So this is the idea to design the null hypothesis and alternative hypothesis based on your research question in your study. Now, there are two types of alternative hypothesis. Sometimes we often encounter with the two-sided alternative hypothesis and one-sided alternative hypothesis. Generally, we are not very much sure about the direction of the results, in which particular group the systolic mean blood pressure will be high, in group 1 or in group 2. And we don't have idea of the direction of the result. In that case, most of the time we design our alternative hypothesis as a two-sided alternative hypothesis. The one-sided alternative hypothesis is very rare, and when we do not have the background information, But one example could be for the one-sided alternative hypothesis is non-inferiority trial design, when an investigator try to see whether the new drug is almost as good as the standard therapy, or it is not much worse than the standard therapy. When we have the directional idea of the effect of a treatment, then we can design our alternative hypothesis as a one-sided alternative hypothesis. So now the question is, what is the aim of hypothesis testing? Usually one can say that we can find out the the incidence of measles in the children who is vaccinated, and the incidence of measles among the children who are not vaccinated, and we can calculate the difference in the incidence of measles, and we can say if the observed difference is substantial, we can say that this is because of the vaccine program. So the reduction of 40% we have observed in the the vaccinated group, and this is because of the vaccine effect. But in the simple the simple calculation, we are not very much sure about the difference what we observed. It is because of the sampling variation, or it is the real effect of the vaccine, or real effect of the treatment, or real effect of the exposure on the outcome. So the aim of the hypothesis testing is to give the explanation whether the observed difference between the two groups, or the relationship between the two parameters, it is because of the sampling variation, or it is actually because of the real relationship. Now, when we do the testing of hypothesis, there are two possible scenarios. Either we can reject the null hypothesis, or we fail to reject the null hypothesis based on the evidences we collect on our sample data. But when we reject the null hypothesis, when we reject the true null hypothesis, then it means that we are allowing some kind of error, which is known as the type 1 error. Because as I said previously, that the null hypothesis can be true, can be false, because this is a hypothetical. Sometimes our belief can be a null hypothesis. So that can be true, that can be false. So if the something which is true and we try to reject it, then it means that we are performing some kind of error, we are allowing some kind of error, and that is the type 1 error. This type 1 error is also known as the level of significance, and the complement of this level of significance is the level of confidence. Then the second type of error is when we fail to reject our null hypothesis, when the null hypothesis is false. Something which is false, so we should reject it, but we do not reject it. We do not have enough evidence to fill the false hypothesis. Then we are allowing the different types of error, popularly known as the type 2 error, and noted as a beta error. And the complement of this type 2 error is 1 minus beta, which is the power of the test, and we also say that this is the power of the study. So our goal in any study is to minimize these two errors in the experiment. So in the planning stage itself, we should be very sure about that what should be the type 1 error and what should be the type 2 error, and we fix at the planning stage during the sample size computation which sample size would be the representative sample size for the study. That depends on the how much we are allowed the type 1 error in our experiment, and how much we are allowed the type 2 error in our experiment. Now, what is p-value? So the p-value provides the evidence against the null hypothesis, so we can prioritize our alternative hypothesis. So what is null hypothesis? There is no difference in the incidence of the measles, right? And what is alternative hypothesis? There is a difference in the incidence of measles. So p-value will provide us some evidence so that we can reject the null hypothesis and we can believe about our alternative hypothesis. That depends on what is the magnitude of the p-value. So p-value is actually the p means probability. So p-value means the probability of the observed difference when the null hypothesis is true. If the null hypothesis is true, that there is no difference, if that a statement is true, then how it is possible that there could be an error? There could be a type 1 error. So it is possible because we are not working on the entire population. We are not working on the entire target population. We always work on the sample data. We draw some samples from the population. So always there is a chances that there could be a the sampling variation or the chance probability. So This probability value is the probability of observed difference when the null hypothesis is true. And we can also say that the probability of observed difference because of the sampling variation, because of the chance. So this probability value is, if it is the p-value is close to 0, means that the observed difference is unlikely due to the sampling variation. Whereas if the p-value is close to 1, that means that there is no difference between the group other than the random variation. Now, this is the conventional guidelines of the p-value, where we can decide and we can interpret our findings, our results. If the p-value is less than 1, it means that we have a very strong evidence against the null hypothesis, and we can prefer our alternative hypothesis, and we can say that our result is highly significant. If the p-value is between 1% to 5%, still we have moderate evidence against the null hypothesis, because the p-value is, again, I'm telling that this p-value is the probability of observed difference because of the sampling variation. So if the p-value is less, as minimum as possible, it means that the higher probability is towards the observed difference because of the real effect, because of the real treatment effect or real vaccine effect. So if this p-value is in between the 5% to 10%, it gives us a suggestive evidence. And if it is more than 10%, then there is a little evidence, or there is no evidence against the null hypothesis. And we can say that the observed difference is not because of the vaccine, is not because of the treatment, it is because of the sampling variation. Or we can say that we do not have enough evidence to reject the null hypothesis. Now, often we encounter the clinical significance versus a statistical significance. This is a very popular discussion, and a lot of literature has come in the recent years. So sometimes what happens that even a small difference between the two groups may be statistically significant, which hugely depends on the sample size. If you have recruited a lot of patients close to your, the target population, then even the small differences between the two groups could be statistically significant, but it may not be meaningful for the clinical investigator. Sometimes also possible that when you work on the very, very small sample size, your design is very poor, you could not plan well at the planning stage, then your small study may fail to detect the substantial effect, a big difference between the two groups, which may be very, very meaningful for a clinical investigator, but the p-value will not support your result. It will it will be non-significant, and you think that the observed difference is because of the sampling variation. It's not because of the sampling variation. It's because of the we have not adopted the representative sample size in our study, and that's the reason that even the genuine effect could not turn into significant. So the confidence interval is the additional index needs to be supplemented along with the the observed estimates and the p-value, which will tell us about the precise whether our observed result is precise or not. It gives us an idea about the reproducibility of the result. So when you repeat your study under the identical protocol again and again, so most of the time your results will fall into the stipulated limit of the lower limit and higher limit. It will not go beyond the the confidence interval. So for an example, if you you have computed the 95% confidence interval, so if you will do your study multiple times, let's say 100 times, then the 95% of the times, if you will repeat your study under identical protocol, under the same settings, your results will not go beyond the 95% confidence interval. It will always fall within the 95% confidence interval. But the justification of whether the result is significant or not, it not only depends on the p-value, but also it depends on the whether your confidence interval is precise or not. Let's say in the vaccine example, if the vaccine reduce the incidence of measles by 40%, but if your 95% confidence interval is like 5% to 95%, then your the reduction incidence is not reliable, because sometimes if you will repeat the experiment, it could be like 6%, 7%, and sometimes it could be 87% reduction. So the 95% CI will give us the precise idea whether our result is precise or not. And the another thing is that when we repeat the study, it will it will not go beyond the range. So always nice to supplement the confidence interval along with the actual observed difference and p-value in our result section. So as a summary, the null and alternative hypothesis must be chosen before the data collection at the designing stage. And we should note that the aim of hypothesis testing, even I have said that accept or reject, but is not the accept or reject the null hypothesis. Actually, it is simply to guess the observed difference, whether it is genuine, it is because of the real treatment effect, or it is because of the the sampling variation. And the level of significance needs to be set before the test is carried out, so that we can prefix the the type 1 error in the beginning. So always our idea to doing a research is to minimize the error as much as possible. So a minimum error we can use to design our experiment in terms of sample size computation. And the p-value is not the beginning state, it comes the later stage when we when we analyze the data. So p-value is the can be observed after the study is complete and based on our observed result. A p-value is the probability that an observed effect is simply because of the sampling variation, and it never tells about the observed effect size. Thus the presentation of both the actual p-value and the confidence interval is desirable. And we should note that the statistical significance and the clinical importance are not the same things. It needs to be clearly interpreted in our discussion section. Thank you.